to talk to you about non-union of the fracture. Well, it is defined as the state in which all the healing processes has come to a halt beyond a stipulated period of healing for a particular bone, and the bone will not unite without some additional intervention. FDA has defined it as minimum 9 months have elapsed since injury, and the fracture shows no visible progressive signs of healing for the last 3 months. And AO has defined it as if the fracture remains ununited for 6 to 8 months. So there are different definitions. If we see the fracture healing involves a complex and sequential set of events to restore the injured bone to a pre-fractured condition. Fracture stability dictates the type of healing that will occur. The modes of bone healing are either primary bone healing or secondary bone healing. The primary bone healing occurs when absolute stability is provided to a fracture by fixation, resulting into no callus formation. Normal bone architecture is restored when osteoclasts provide a guide for the blood vessels to cross the fracture site. A clinical example is healing of fracture with a compression plate. This occurs when secondary bone healing occurs when there is a relative stability to the fracture fixation, resulting in good callus formation. The clinical examples are fixation with K wires or external fixators, or simple casting or splinting, or intramedullary nailing, or lock plating with minimum screw getting engaged into the holes. The stages of bone healing are first hematoma formation. This hematoma forms and provides a source of hemopoietic cells capable of secreting growth factors. These cells are macrophages, neutrophils, and platelets, which release several cytokines, including PDGF, TNF alpha, TGF beta, and interleukins 1, 6, 10, and 12. Then there is a process of inflammation wherein the fibroblast and mesenchymal cells migrate to the fracture site and granulation tissue forms around the fracture ends and osteoclasts remove the necrotic bone. Then is a stage of proliferation of periosteal and endosteal cells at the level of the broken cortex, and that leads to callus formation and transformation from a soft callus or osteoid to a hard callus by calcification. And the final stage is remodeling of a woven bone to a lamellar bone. This is a diagrammatic representation of how from a normal bone to a process of remodeling takes place through various stages which we described. There are different factors affecting the fracture healing. There are local factors, the fracture characteristics like excessive movement, malalignment, excessive damage to the bone ends, and covering soft tissue. And soft tissue interposition can lead to delayed or non healing of the fracture. Infection, if it is present, can lead to poor healing and delayed or non union because it doesn't allow the healing process to take place. And disturbance to the blood supply or reduced blood supply to the fracture site can lead to the delayed or non union. The systemic factors which are responsible for the delayed healing are the advanced age, obesity, anemia, endocrine conditions like diabetes, parathyroid problems, and menopause, steroid administration, malnutrition, smoking, sarcopenia, and osteoporosis. In today's days, what we practically use is what is called as a caste theory of non-union. Caste theory, the four words indicate C is for contact of the fragments, A is for alignment of the fragments, S is for stability at the fracture site, and the last S is for stimulation of osteogenesis. If any one or more factors of these four are involved, it can result into non-union. The non-union can be either aseptic or infective. The classification of aseptic non-union was first done by Weber and Sage, which is now accepted by the O classification, which divides it into hypertrophic, oligotrophic, and atrophic. Pele modified Elizaro's classification. The Evo or Weber-Sech classification, in a hypertrophic non-union, there is a reactive or hypervascular non-union. It is usually due to mechanical failure or instability, which leads to florid callus. There is a good blood supply, and it heals only by providing the stability to the fracture. Atrophic non-union is because of the biological failure, and there is a non-reactive bone ends, or it is more or less totally avascular bone end. There is absence of callus, and this requires bone grafting or additional electrical stimulation or ultrasonic stimulation. Hypertrophic non-union can be divided into elephant foot non-union with lot of callus formation, horse hoof non-union with mild hypertrophy and poor callus, and oligotrophic non-union where the bone ends are vascular but there is no attempt of callus formation. This is a diagram showing these three types. Then atrophic non-union can be divided into torsion wedge, where there is a presence of intermediate fragment which has united at one end but not the other side because of improper vascularity. Can be comminution, wherein one or more fragments are avascular or necrotic, which hampers the union, or there can be a defect which can lead to a loss of diaphyseal fragment, and it can be a atrophic non-union with tapering sclerotic bone ends. Paley et al. Classified the non-unions into three different types. Type A is non-union where there is a less than 1 centimeter bone loss. It is again divided into A1 where there is a lax non-union, and A2 where there is a stiff or non-mobile non-union. In A2 type, there is again type 1 and type 2, depending on whether there is any deformity or there is no deformity. A type B non-unions is more than 1 centimeter of bone loss, and it is divided into again B1 where there is a bony defect but there is no shortening. There is B2 where there is shortening but there is no bony defect, and B3 is there is both bony defect as well as shortening, and type C is infected non-union. The features of non-union are there is a duration of more than 6 to 8 months, there is no or minimal pain, or there is abnormal mobility at the fracture site in most of them, and the X-ray shows sclerosed bone ends, closed medullary cavity, and presence of a gap. The objectives of treatment are there should be healing of fracture, correction of deformity, correction of limb length discrepancy, mobilization of adjacent stiff joints, and eradication of infection if it is there. The investigations which are required are, in addition to the blood profile, the plain X-rays, CT, MRI, and sometimes a technetium bone scan or radioisotope scan, which gives idea about the vascularity, synovial pseudoarthrosis, and hypertrophic non-union. Let's see what is the treatment of aseptic non-union. If there is good reduction achieved and good alignment, or there is a sufficient contact, if there is a stable fixation, or if there is a stimulation of bone healing by bone grafting, corticotomy, or bone marrow injection, or electrical or ultrasonic stimulation, you can get healing of this particular fracture.